Hi, welcome to our channel of IGNOU Audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS. Postgraduate Diploma in Hospital and Health Management, PGDHHM, revised. MHH 102 Hospital Services. Volume 1. Block-1 Clinical Services I. Unit-3 Operation Theatre, 3.0 Objectives. After going through this unit, you should be able to describe the objectives of planning and operating department, perform quality control procedures, describe the concept of zoning and advantages of zoning in the operating department, describe methods of calculating the number of operating suites required, describe the various elements to be considered while designing an operation theatre department, and describe the policies component in any hospital. They represent the central and glamorous life-saving activity. You will learn about the need of proper planning of the operation theatre department and elements of planning. In this unit you will also learn about the essential policy and procedures which are required to be laid down for strict adherence by all concerned. 3.2 Types of operations. Emergency operations is that which must be carried out as soon as possible after the diagnosis has been made, and the patient is prepared for the operation. Emergencies from outside include patients who are admitted as urgent cases. In case of the inpatients, emergencies, in a case like a wound dehiscence or post-operative intestinal obstruction, the decision is made by surgeon in charge of the patient. Elective operations, which are the majority, are carried out sometime after the diagnosis has been made and when the suit best for the patient and the hospital. Currently there are at least 15 surgical specialties or subspecialties which require operation theatre to be equipped with special equipment. Some of the advanced surgeries are listed below. Microsurgery, it may be defined as the surgery performed under magnification. Some people confine it to the surgery using the operating microscope, while other includes loupes and other ocular aids. Microsurgery has proved its usefulness in otorhinolaryngology, ophthalmology, neurosurgery, peripheral nerve surgery, vascular, plastic and hand surgery. Cryosurgery. Cryosurgery is that type of surgery which based on use of liquid nitrogen at a very low temperature. Nitrogen is brought into contact through prop with diseased tissue which dies and sloughs away. In this local pain is absent. Laparoscopic surgery. Major surgical interventions are done with the help of laparoscope. This surgery requires minimal incision, post-operative care and stay in the hospital. Biomedical laser, light amplification by simulated emission of radiation is one of the ways to make the conventional scalpel obsolete. In this procedure, there is absence of physical contact, and the cutting is without mechanical pressure which makes the operation non-traumatic. The risk of infection is also less. 3.3 Operating Complex. In order to facilitate any of such operative procedures, it is important for any hospital management to create a physical facility conducive to scientific requirement and provision of support manpower. At the same time, the machinery and equipment required have also to be catered to, depending on such facility and provisioning of the equipment. Concepts of operating theatre, operating suite and operating department are described below. 1. Operating theatre. An operating theatre is the room in which surgical operations and certain diagnostic procedures are carried out. 2. Operating suite and theatre suite. An operating suite comprises the operating theatre together with its own ancillary areas, namely anesthetic room, a room for setting up instrument trolleys, a disposal room, a scrub up and gowning area and an exit area which may be part of the circulating space of the operating department. 3. Operating department. It is a unit consisting of one or more operating suites, together with ancillary accommodation provided for the common use of these suites such as changing room, restroom, reception, transfer, and recovery area and circulating space. 3.3.1 Modular OT. Modular operation theatre is a modern concept of operation theatre where all modern technology is introduced to provide best possible surgical care to the patient. This covers OT table with laminar airflow which purifies air within the OT through a HU and HEPA filter. Modular operation theatre focuses on achieving safety, precision, and efficiency for the entire operating team. It is designed to streamline the workflow and deliver better patient outcomes by eliminating wasted time and resources. Modular operating theatre drives consistency, smooth flow during operations, and reducing the risk while carrying out surgical procedures. Modular OT specifications: absolute flatness, vertical level adjustment of subframe, hermetic sealing, sound insulation, non-flammable materials, ease of disassembly, individuality of panels. Benefits of modular OTs in the hospital: imaging diagnostics during operation, patient safety, collaborative environment, cost savings. There are 4 major components that need to be installed in modular OTs. This includes 1. Control panel, 2. Ceiling mounted laminar flow, 3. X-ray screen, 4. Surgical scrub platforms. 3.3.2 Hybrid operating theatre. A hybrid operating theatre is a surgical operating theatre equipped with advanced medical imaging devices. This will accommodate complex surgical work including advanced cardiac and endovascular clinical procedures. It is an advanced procedural space that combines a traditional operating room with an image-guided interventional suite. This combination allows for highly complex, advanced surgical procedures. Not only are the rooms combined, but the teams are combined too. Form a multidisciplinary group of clinicians prepared to meet the complex needs of patients. 3.3.3 Integrated operation theatre. Integrated operation theatre usually refers to systems integration, which means functionally connecting the OT environment. It includes integration of patient information system, audio, video, surgical lights, and room lights, building automation, HVAC, medical equipment, telemedicine, video conferencing, etc. The integrated theatre's framework allows all technology and data components within an operating theatre to effectively work together. As a result, audio, video, pendant lights, and room lights all function together, enabling a higher quality and more comfortable surgery for both patients and surgeons. In addition, this advanced integration is more time efficient as it negates the need for switching between multiple equipment. When integrated, all technology can be manipulated from a central command console by single operator. Integration in OT holds the key for effective application of minimally invasive surgery, robotic surgery and functioning of hybrid OT. Check your progress. 1. A. Elective operations are carried out. B. Cryosurgery is based on. C. In case of inpatient emergencies, the decision to operate is not made by the surgeon in charge of the patient. 3.4 Planning. Aims of planning of an operating department are to promote a high standard of asepsis, to ensure maximum standard of safety for patient and staff from environmental, anesthetic, radiological and post-operative hazards, to ensure optimum utilization of operation theatre and staff time, to ensure optimum conditions of work for the surgical team, to ensure comfortable treatment of patients. Planning criteria. In order to achieve the above objectives, it is imperative that the operating department be so designed that they meet the functional, professional, and technological requirements. The planning criteria so developed are: A. Functional criteria. The activities to be carried out in different functional areas of the operating department are to be critically studied and analyzed. The design of the operating room must follow the functional requirement of the operating department. B. Economic or workflow criteria. The flow of patients, supplies and staff in an operating department is to be conceived and pre-planned. This will ensure optimization of relationship between Various functional areas of the operating departments. C. Environmental criteria. The environmental aspects should also be considered for the safety and comfort of the patient and staff. The complexities of the functional and workflow criteria will create numerous problems while designing an operating department and formulating its operational policies. After a thorough study and analysis of the above criteria, the design considerations must be identified, which will decide the operating policies for the organization and management of the department. 3.5 Designing considerations. Before designing an operation theater department, one should try to understand the various activities involved in operating a patient. There are a number of activities which are involved with the basic procedures, while some other activities are supporting procedures and administrative activities. These are as under: A. Basic activities involved in the act of surgery, reception and identification of patient, pre-operating supervision of patient, depilation of patient to operation table, administration of anesthesia, intubation, positioning, preparation of the operative area and surrounding skin, draping of patient, the act of surgery, operation, which may involve blood transfusion, parenteral fluid administration and X-ray examination, wounds sewn up and dressed up, drapes removed and bagged, extubation, transfer of patients from operation table to trolley or bed and to the post anesthetic recovery area, post-operative supervision of patient. B. Supporting procedures, staff changing to operation room garments and shoes, putting on cap, masking, aseptic washing of hands, gowning, putting on gloves, putting on apron, laying out, checking and rechecking the number of instruments and dressing to be used during the operation. C. Administrative procedures, preparation of operation lists, duty schedules, requisition of patient, notification to wards of time for patient transport to and from the surgical department, distribution of messages, requisition of records, equipment, and material, contacts with other departments, laboratories, workshops, and suppliers, ensuring availability of essential doctors and supporting staff for emergency assistance. D. Clerical procedures, preparation of operation records, preparation of operation rooms records, filing, statistical interpretation of operation room records. A. Housekeeping procedures, collection of used instruments, collection of used materials and soiled surgical instruments, dressings, and underlays, cleaning of operation rooms and other areas in the surgical department, disposal or incineration of refuse. 3.5.1 Location. Location of operation theatre or suite in the hospital building needs detailed consideration. It should satisfy the following basic conditions in the overall layout of the hospital. The principles of locating operation theatres are: 1. Quiet area located to provide isolation from mainstream of common corridor and traffic in terms of staff, supply, and visitors. 2. Should get least exposed to any source of direct contamination of dirt or microbe. 3. Hospital support service facilities like CSSD, Central Sterile Supply Department, X-ray, laboratory and blood bank should be preferably in its proximity as far as practicable. The unit also needs constant specialized services such as piped suction and medical gases, electric supply, heating, air conditioning, ventilation, and efficient lift services, if theatres are located on the upper floor in the multi-story building. If possible, operation theatres should be having its own wing, an independent low building. This will help in future expansion of operation theatre complex without disturbance to other departments of the hospital. Operation theatres require more height, approx. 4.2 meters, because of air conditioning requirement of a modern OT. It is therefore felt, if there is only one multi-story building of a hospital, then 0T should be located on the top floor of the building because of ease of providing more height. Dedicated, AHU, air handling, Unit for 100% fresh air for each OT, for blow-through system, could be situated on the terrace of the multi-story building above the operating room. 3.5.2 Size of the operating room. Minimum clear area for a general operating room is 40 square meters. Cardiovascular, neurosurgery, orthopedic and other specialized procedures which require additional equipment needs minimum clear area of about 60 square meters. An additional adjoining room to the main OT may be needed for heart-lung machines for cardiovascular OT. And equipment storage for large equipment in other specialized operating rooms. In orthopedic surgery, space may be needed for splint and traction equipment. Surgical, cystoscopy and other endourological process, room will require minimum clear area of 35 sq meters. 3.4.3 Number of operating rooms. A fully equipped operating room is one of the most expensive facilities to build and maintain in a hospital. It follows that the number of operating rooms should be carefully calculated to achieve their maximum utilization or productivity. Many authorities are of the view that rather than considering the number of operations per day, the number of operating rooms is more significant and it depends on the following factors. 1. The number and types of surgeons available in the hospital, viz. the patients thereof. 2. The number and nature of procedures undertaken in the hospital. 3. The average length of stay of surgical patients in each of the specialty. 4. The average time for operating. 7. The amount of idle time of operating rooms and staff that may be considered necessary. So, it can be well argued that there is no single method for assessing the requirement of number of operating rooms in a hospital. Other factors affecting the operating room requirement are like 1. Location of operating rooms. If they are scattered in different places, it is difficult to ensure the continuous use of each operating room. 2. Size of the operating room. Standard operating rooms normally provide maximum flexibility of use. 3. Working hours and weekly working days of operating rooms. Different authors have recommended various formulae for calculation of number of operations per day in a general hospital with basic surgical specialty. I. Number of operating suites and number of operations per day. The number of operating suites can be found out from the predicted number of operations per day. Macaulay, in his book Hospital Planning Administration, has stated that the number of operations can be calculated by dividing the number of surgical beds by the ALS, average length of stay, of surgical patients. Therefore, number of operations per day equals number of surgical beds x% of BOR x 365. ALS x 100 x number of working days in that hospital. Note: BOR, bed occupancy rate. ALS, average length of stay. The number of operations which can be performed in each operating suite can be determined by studying past trends and by conducting work studies or by making use of available standard norms. American authorities calculate one operating suite for 2 or 3 operations per day, while European authorities recommend that a minimum of 6 operations should be performed per day in one operating suite. 2. Number of operating suites and hospital beds. According to American pattern, one operating suite is required for every 25 surgical beds, while European authorities recommended one operating suite for every 50 surgical beds. Rao Committee, I-968, which was appointed by the Government of India in connection with studying the facilities available in Delhi hospitals, has recommended one surgical theatre for every 50 beds. However, the Committee on Planned Projects, COPP 1964, has given the following guidelines regarding number of operating suites in a hospital. No of operating suites required. Look at the screen. 3.5.4 Zoning. It is universally agreed that operation is to be performed under the most aseptic conditions. To ensure this aseptic condition, the operating department is divided into 4 distinct zones: protective zone, clean zone, sterile zone, Disposal zone. A. Protective zone. It usually provides facilities like I. Reception. 2. Waiting room for patients' relatives. 3. Changing rooms. IV. Pre-anesthesia room. V. Storeroom. V. Autoclave. 7. Trolley bay. 8. Control area of electricity. B. Clean zone. It provides facilities such as I. Pre-operating room. 2. Recovery room. 3. Theatre work room. IV. Plaster room. V. X-ray unit with dark room. V. Sisters work room. 7. Staff work room. 8. Anesthesia store. A. Sterile zone. This zone has facilities like I. Operating room. 2. Scrub room. 3. Anesthesia room. IV. Instrument sterilization and trolley area. D. Disposal zone. This zone provides facilities like I. Dirty wash-up room. 2. Disposal corridor. 3. Janitor's closet. These zones are bacteriological zones of varying degrees of cleanliness. The bacteriological count diminishes from outer to the inner zones. 100% sterility must be ensured in the sterile zone. The zoning of the operating department has got the following advantages. Minimizes risk of hospital infection. Minimizes unpredictable movement of staff, supplies and patients. Increases efficiency of staff working in the operation suites, ensures smooth workflow. Reduces hazards in the operating suites. Ensures proper positioning of the equipment. Ensures optimum utilization of the operating suites. 3.5.5 Operation Theatre Department Layout. Fig 3.1 Layout of Operation Theatre Department. Look at the screen. 3.5.6 Electrical. The administrators and the planner have to ensure the availability of electricity all the time in OT. It is essential to provide foolproof system for stable electrical supply all the time. When the surgical team is operating on the patient or is being resuscitated on ventilator or has been put on heart-lung machine, power supply should never fail even for an instant. Like human beings, mechanical and electrical equipments can get sick and may require repair and maintenance. Therefore, planning has to be done in such a way that if one source gets disrupted, then the electrical supply is available from the other sources to treat the patients on time. 3.5.7 Air conditioning of surgical suite. Air conditioning also helps in maintaining the aseptic condition of the operating room by letting only controlled air to pass inside. It also improves the efficiency of the air conditioning in a broad sense, means air cooling or warming, air humidification or drying and air sterilization to some extent. In an operating suite and more preferably in the whole surgical department, air cooling, humidifying and relatively high sterilization is a must to prevent post-operative wound sepsis. Surgical team, by creating a pleasant environment, helps in maintaining the vital functions of the patient by providing the optimum comfortable environment. In order to provide clean air in sufficient quantity and to remove possible contaminants liberated by the surgical team and patient, it is universally recommended that the ventilation of the emergency operation rooms should provide fresh air at comfortable temperature with adequate filtration or precipitation to eliminate dissemination of bacteria-laden dust. The requirements of air supply to operation room recommended by American Hospital Association, 1962, are as under. 1. Temperature 70-76 degrees Fahrenheit. 2. Relative humidity 55.0% or above. 3. 10 to 20 air changes per hour. 4. 100% fresh filtered air entering from above the roof. 5. No recirculation of air when operating rooms are in use. 6. Positive pressure within the operating room to prevent the entry of air from surrounding areas. 7. Exhaust air taken off from a point near the floor in order to remove dust and heavy anesthetic gases. The most advanced type of air conditioning technique used in such a situation is called as laminar airflow system. In laminar flow or unidirectional type of airflow, air passes through high-efficiency particulate (HEPA) filters and either flows downwards from many vented or gridded ceiling to the flow outlets in a piston-like action at a velocity of 70 to 100 feet per minute or flows horizontally from one side to another. Studies have indicated that this procedure is quite effective in materially reducing the bacterial contents of the air from exposed surfaces. Two types of laminar flow are seen to be in use: A. Horizontal and B. Vertical. Downwards. In practice, downward laminar flow is more appropriate for operating theatre because of its less air velocity, 60 feet per minute. The laminar airflow has the following advantages. 1. Control over the direction of air movements. 2. Rapid removal of organism arising from the surgical team. 3. No cold drafts or discomfort by the operating team during cooling of theatre air. 4. Rapid control of theatre temperature between 65 F and 75 F, 18.3 C to 23.8 C, in a few minutes. 5. Quick dilution of anesthetic gases. 6. Airborne particles are far less likely to agglomerate, as containment will not normally occur. 7. Air stagnation in part of theatre will not occur. Modern air treatment plant for an operating room consists of a blower to move the necessary amount of air, a pre-filter to remove particles, and an air conditioner which heats, cools and dehumidifies or humidifies the air. Current standard requires for operating room air a minimum of 12 to 15 air changes per hour. Positive pressure compared with corridors, temperature between 18.3 and 23.8 C, 65 to 75 F, humidity of 50 to 55% and depending upon the locality, up to 80% recirculation, with the use of effective filtering. In some cases, even 100% outside air with no recirculation is also suggested for the purpose of sterility and infection control in the operation theatre. 3.5.8 Lighting. Lighting, or in other words illumination in an operation theatre, is an important requirement for the efficiency of the services. It is essential to provide adequate light for surgeon, anesthetist, nursing and other staff in the operation theatre complex. The volume or quantity, the quality and the direction of lighting are some of the factors to be considered. The principles of the lighting requirements of an operating room are: lighting of high intensity, capable of speedy and accurate adjustment with good focus, produces minimum heat, illumination of depth of the wound without glare on the surface, near daylight in color, shadowless, freely adjustable to any position or direction, spark-proof and safe where inflammable gases are used. 3.5.9 Manifold facilities. Manifold services are very essential for the modern hospital. The hospital provide high-quality care to the patients of all age group, as well as emergency services round the clock to the seriously ill patients with highly specialized medical and surgical services. Hence, a large number of patients, while they are on treatment, require oxygen in operation theaters, wards, anesthesia rooms and ICU etc. Many of those who undergo surgery, while being given anesthesia, are also administered N2O. Nitrous oxide gas. Objectives of department. The services include providing medical gases like oxygen, nitrous oxide, compressed air and suction through the centralized pipeline system to the wards, operation theaters and ICU etc. These gases are supplied from manifold plant, round the clock. In every shift, there is technician, plant operator to maintain proper and regular supply of above said gases. Pendant. Pendant means hanging. Service pendant are ceiling mounted and provide manifold and electric outlet at convenient height for use. Oxygen, nitrous oxide, compressed air, and vacuum outlet are provided in the pendant. Electric sockets which are on UPS are also provided in the pendant. The pendant with manifold facilities is located near the anesthetist end of the operation table. 3.5.10 Structured cabling. Cabling is the foundation of functional IT networks. Network cables are necessary to connect and transfer data and other information between computers, routers, and storage systems. Network cables are like veins in the human body. They are carriers that allow data to flow from one place to another. There are two major types of cable assemblies used in the operating room: patient monitoring assemblies and surgical assemblies, and some others that are very specialized. Patient monitoring assemblies are used to track the patient's vital statistics, such as blood pressure, pulse, ECG, EKG, ICG, electrocardiogram, heart monitoring, temperature, blood oxygen and carbon dioxide levels, and other factors important to the surgical team in assessing how the patient is doing during the surgery. Therefore, structured cabling for present and future use has become a necessity and should be planned well in advance. 3.4.11 Plumbing, sanitary installations. The provisions that are encountered by the plumbing professionals in the design of a healthcare facility are plumbing fixtures and related equipments, the sanitary drainage system, water supply system, laboratory waste, vent system, pure water system, room of OT, in which gowning area should be provided. 3.4.12 Firefighting. Operating room fires are not rare but is preventable danger in modern healthcare operating rooms. Optimal outcomes depend on all operating room personnel being familiar with their roles in fire prevention and fire management. Despite the recommendations of major safety institutes, this familiarity is not in current practice in many healthcare facilities. Members of the anesthesiology and the surgery departments are commonly not actively involved in fire safety programs, fire drills, and fire simulations that could lead to potential delays in prevention and management of intraoperative fires. 3.4.13 Design. 3.4.14 Equipment. The term equipment in the hospital administration context covers all items necessary for the functioning of the hospital and includes both non-technical, e.g., furniture, and technical equipment. Short-term consumable supplies such as fuel, stationery, food, drugs and dressings are not included under the broad heading of equipment. Equipment is classified into three groups and the examples of such equipment belonging to each group pertaining to operation theaters are given as below. Group I. Items usually supplied and fixed by the contractor for the facility like piped anesthetic gases, suction, and oxygen connectors, illuminator, X-ray dryer film, double socket outlet, voltage socket outlet, X-ray apparatus, clock, electric, and lamp, operating theater lights etc. Group 2. Items having a permanent or semi-permanent location and having a significant effect on space and or structural requirement which may either be supplied by hospital authorities and fixed by the contractor or supplied by hospital authority and put in position by them like operating table, trolley, dressing, surgeon's stool, stand blow, single and double, stand drip, and table, instrument. Group 3. Smaller items, usually storage items, supplied and put in position by the hospital authorities like sphygmomanometer, stethoscope, thermometer etc. Further, such equipment can also be grouped in three categories based on the methods of purchase and on suggested accounting practices in regard to depreciation. Group 1. Built-in equipment included in construction contracts like hospital cabinets, fixed sterilizing equipment and surgical lighting etc. Group 2. Equipment of 5-year life or more, not normally purchased through construction contracts. Large items of furniture, other than construction contract, small items of low unit cost and suited to storeroom control. Examples are chinaware, silverware, waste basket, dressing jars, catheters, surgical instruments, linen, sheets, and blankets etc. 3.4.15 Staffing. The principle of staffing in an operation theatre complex should be that of self-sufficient in terms of the experience as well as the number of its staff. Apart from exceptional cases and to meet disaster situation, it should be able to deal promptly with anything, anytime, from within its own resources in all areas like nursing and paramedical as well as medical staff. For the administrative convenience and keeping in mind the concept of the unity of command, the staff should be under the administrative control of officer in charge of Operation Theatre Department. The following categories of staff are commonly in position: specialists, surgeons, anesthetist, resident staff, senior resident, junior resident, nursing, assistant matron, assistant nursing superintendent, nursing sister, staff nurses, student nurses, when applicable, technical, X-ray technicians, radiographers, technical supervisors, operation theatre technical assistants, operating room attendants, operating theatre attendants, others, sanitary personnel, nursing orderlies, security guard, peons or messenger, clerks or medical transcriptionists when available. 3.6 Policies and Procedures. 3.6.1 Operating Schedule. In order to make effective use of operation theatre facility, the most important factor is drawing the operation schedule. The time lost between cases in a given operating theatre may amount to as much as 15 to 50 minutes depending upon the hospital, its personnel, the number of surgical instruments available and discipline prevailing in the theatre. It is important to ensure that there is no wastage of operating time of the surgical team nor there is any overcrowding of the operation list resulting in postponement of operations. Some of the issues which should be in mind of all concerned are given in succeeding paragraphs. The most important of these are I. Discipline of OT. E. Availability of instruments. 3.6.2 Administration of OT. Time-saving technique depends considerably on operating room discipline. A well-run OT requires an untiring and energetic theatre matron, a dedicated and disciplined chief surgeon, an anesthetist who is keen on high standard of efficiency and trained in well-motivated paramedical staff. If instruments are ready in advance of the appointed time, if the assistants are in the room, gowned and gloved, and the anesthetist helps to coordinate the presurgical details before entry of the operating surgeon, the duration of occupancy of that room by a particular patient will be decreased considerably. 3.6.3 Punctuality. Punctuality by everybody concerned with the operating schedule is important. It is to be impressed upon to all that the first case of the day should begin promptly when scheduled, i.e., operation may be at 08:00 HRS. All delay in starting a procedure should be investigated and discipline enforced with suitable penalties and motivation. 3.6.4 Theatre Staff. The chief of the surgical team should always take personal interest in the training of theatre staff. Each member of the team, including the junior-most operation room assistant, ORA, and even the sweeper, should be put through progressive training to bring them to a high pitch of efficiency so that they carry out their duties more or less by reflex action or mechanically. 3.6.5 Operating List. It is imperative to make the operation list judiciously, and tentative time of operation, when possible, should be indicated against each. Efforts should be made to ensure that the cases are not postponed barring unforeseen and exceptional circumstances. Rigidity of working hours should not normally be allowed to come in the way of completing the list for the day. Other reasons for postponing operations, such as non-availability of theatre linen, lack of sufficient instruments and inadequate preparation of patients, should be reduced to the minimum by suitable administrative measures. 3.6.6 Outpatient Cases. It is a common practice that some outpatients, who requires minor surgical procedures, such as special dressing, change of plaster, injection of piles, incision of a whitlow in, so on, reporting to the OT early in the morning and being taken up late in the afternoon. at the end of the list. This practice not only puts the patients into inconvenience but also creates avoidable dissatisfaction of patients and their relations. Few of the suggestions which can be implemented are: A. Awareness on the part of all concerned staff that the above practice is highly demoralizing to the patients and all efforts should be made to plan and organize prompt attention for OPD cases. B. Where there is only one surgeon in a hospital, such cases should be dealt with either on OPD days in the afternoon or on the following day in the morning, using the minor OT. C. Where more than one surgeon, trainee or resident staff in surgery is available, the OPD surgery should be listed separately for the day and a surgeon detailed for the same. Separate provisioning of anesthesia service is always necessary. For this, D. All outpatients scheduled for such procedures should be called by appointment at the appropriate time when they are expected to be dealt with. 3.6.7 Transportation of patients. Transportation of patients from into the ward should be organized only by the anesthetist at a suitable time depending upon the time of operation. For this purpose, adequate ambulance, nursing assistance should be made available on a regular basis. 3.6.8 Maintenance of OT and aseptic standard. Appropriate time should be there for normal maintenance of OT. Swabs should be taken from various areas of the OT to check the growth of bacteria. AC of OT should be checked thoroughly. Filter should be maintained properly. Manifold facilities in the OT like oxygen, suction, compressed air, and nitrous oxide are important. Adequate pressure should be maintained all the time. 3.6.9 Outcome Key Indicators in OT. Few common intraoperative KPIs. On-time case start. Day of surgery cancellation rate. Theatre utilization. Early finishes, late finishes. Booked versus actual time, prediction bias. OR turnaround time. Average case changeover time. Average late start minutes. In-room to cut time. Closure to out-of-room time. Percent of case with delay. Total minutes lost in delays. Average minutes, delay. Emergency cases. Few common post-operative KPIs. Bed assigned to ready to move. Ready to move to occupy bed. Ready to sign out to sign out. Number of patient holds in PACU. PACU length of stay, loss. Complications post-surgery. Unplanned return to OT. Check your progress for 1. It is important to ensure that there is no wastage of operating time of the surgical team nor is there any overcrowding of the operation list resulting in postponement of operations. TF. 2. All outpatients scheduled for such procedures should be called by appointment at the appropriate time when they are expected to be dealt with. TF. 3. List some of the outcome indicators of operation theatre. 3.7 Summary. In this you have learnt about that the reputation of the hospital is determined by the performance of OT complex. This is here where the real action lies. It is here a clean, aseptic environment is provided, where a surgeon performs operative procedures with the objective of curing the illness of patients. You have also learnt about the types of operations and necessity of proper planning of the operation theatre department and elements of planning. It is, therefore, essential that the operation theatre department is planned properly. Location, grouping, size are important elements. Aseptic environment can be ensured if proper zoning is carried out and the best possible air conditioning facilities with good control on ventilation system, temperature, and humidity. Further, you have learned that stable electricity is an important element, important policy and procedures, issues. Consideration. You learned that planning and creation of facilities is important, but it is necessary that it is staffed, equipped, and organized properly. The policy and procedures should be laid down and adhered to. Any lapses in this are likely to adversely affect its functioning and spoil the image of the hospital. Thank you for watching. We will see you in the next video with the next chapter.